Next 15 minutes I'll be talking on this newer molecule, that is bempedoic acid, pill that thrills. This bempedoic acid is the new kid on the block for optimizing LDL goals in India, which is now available. This has already been approved by US FDA and EMA in 2020 for adults with established ASCVD or heterozygous familial hypercholesterolemia requiring additional lowering of LDL. The combination of bempedoic acid and ezetimibe is approved by FDA in 2020 for similar indication, and this combination is available in the United States and other countries, not at the moment in India, and bempedoic acid is approved by DCGI 25th May 2020 and is available in India. So let's talk on the current status of bempedoic acid in the Indian context. So first I'll try to show lipid management prior to the bempedoic acid availability. Then I'll talk about very briefly on the pharmacology of bempedoic acid and the current available data on it. And lastly we'll see, will bempedoic acid be a game changer for lipid management in India? So let's look at the lipid management for ASCVD prior to the bempedoic acid era. Statin, we have already seen this slide. They are the foundational therapy, and the king statin cannot be replaced. So let's see what percentage of patients in real life statins is able to achieve the LDL goals. This is data from DICE, the European and the Canada data, and the Pan-Asian data. You can see if we use high-intensity statin, only 50% of patients achieve their LDL goals. And if you achieve your LDL goals, as you can see on the left-hand side of the slide, the cardiovascular events are decreased by 22%. Another data, if your LDL goal is less than 100, 23% do not achieve the goal. If your LDL goal is less than 70, 76% do not achieve the goal. If the LDL goal is less than 100 in HeFH, 80% do not. So statin is a wonderful drug, is a foundational therapy, but is not self-sufficient. Look at this. If your LDL goal is less than 70, 30 to 40% which achieve the LDL goals with statin, and if your LDL goal is less than 55, only 18% would achieve the LDL goals. All trials, primary prevention, secondary prevention, plaque regression, shown LDL lower is better. So when statin failed to achieve the goal, what do? You use ezetimibe, and you have this drug which enables cholesterol absorption from the gut, and a combination of statin and ezetimibe is a very good combination, because if you increase the dose of statin and double it, the cholesterol reduction LDL is only by 6%, but if you use statin even 10 milligram with 10 milligrams ezetimibe, you have LDL reduction 18%. If you use 10 milligram with high intensity statin, the results are magnified. And Emporic trial all of us are familiar with, is a positive trial, 10% significant reduction in the primary endpoint, and this is the benefit of simvastatin plus ezetimibe, that you decrease non-fatal amide right on the top in yellow color, statistically significant. You decrease non-fatal stroke. Number two, you also have a decrease in the revascularization, but in unstable angina, cardiovascular death are not much affected. When statins plus ezetimibe fail to achieve the LDL goals in high-risk patients, what do? We used to resort to PCSK9 inhibitors, but all these molecules are very costly behind the reach of a common man to use it for a long period. So here comes the first role of bempedoic acid for achieving LDL goal in high-risk patients like established ASCVD or HeFH, and this will help to minimize the use of PCSK9 monoclonal antibodies. But before discussing this, let's have a very brief peep in inside the pharmacology of bempedoic acid. As you can see, bempedoic acid is a prodrug. It has to be converted into active drug by this enzyme, ACVL1. This enzyme is present in the liver, but not present in the muscle. So this agent, when you give, will not be converted into the active form in the muscles, and therefore it doesn't have the muscle toxicity of statins. Secondly, it blocks or inhibits the synthesis of cholesterol ahead of the statin pathway by blocking this ACL, which is adenosine triphosphate citrate lysis. So there's diminished synthesis of cholesterol, LDL receptor gets upregulated, and you have reduction in LDL cholesterol. The drug is metabolized in the liver by glucuroid conjugates, and therefore interaction with CYP3A4 other cytochrome is not there, and is excreted in the kidney through this OAT channel, organic anide transporter. What is important to remember is that this is the same channel through which uric acid and creatinine are excreted, and that's why we'll see in the side effect the uric acid can get elevated, and you have to be careful. These are the pharmacokinetics. I think if you want to look at the absorption, the Tmax of 180 milligram tablet, 3.5 hours, volume of distribution 80 liter, protein binding 99%, rote elimination 70% in the urine, 30% in the feces, half-life 21, no food interactions. So when we are using in renal impairment, no dosage adjustment is necessary, but this is for mild and moderate CKD, severe CKD end stage, not been studied. Hepatic impairment, no dosage adjustment, mild to moderate, but no data in severe hepatic impairment. If your uric acid is elevated baseline, you have to monitor it and treat it, or if you have gout, again you have to monitor uric acid and treat it. So increase vigilance for hyperuricemia and gout. Tendon rupture is a very rare complication, but you have to be careful that if a patient has a history of tendon rupture, you should avoid or should tell the patient very clearly that he should stop the drug on slightest effect on the tendonitis or pain and joints or pain in the tendon. So consider patients who are more than 60 years, these are the factors which predispose to tendon ruptures, taking steroids, fluoroquine, renal failure, and a history of tendon rupture. So if this is the state of affairs, you have to be cautious, and you may even consider discontinuing if the patient on bempedoic develops joint pain, swelling, or inflammation. And if tendon rupture, you have to immediately stop it. The incidence is 0.3 per 1,000 patient years. In the Clear Harmony and the Clear Wisdom, which has statin on board, no tendon rupture was seen in patients who did not in the statin intolerant groups. So somehow it is more related to the drug which the patient is using rather than the bempedoic itself. And all patient tendon rupture occurred in patient during moderate or high intensity. Another precaution is if you are taking simvastatin more than 20 per hour, avoid this combination and consider lowering or switch to other statin. Now this is an example of tendon associated with simvastatin ezetimibe. So even if you are not using bempedoic acid, tendon rupture does occur. It is more related to these drugs rather than the bempedoic acid. Pregnancy, of course, discontinue unless the benefit outweighs the risk, and breastfeeding not recommended. Now this you have to remember that clear means cholesterol lowering with bempedoic acid via ACL inhibition regimen. So any trial which has a clear name, this is bempedoic acid trial. So the bempedoic data started in 2010, and we have very clear trial, Clear Harmony, Clear Wisdom, in Clear Serenity, Clear Tranquility, Clear Outcome. All these are ongoing. We are keenly awaiting the result of the Clear Outcome trial, which is expected this year. These are the 4 trials, 2 trials in patients who are already on statins, the Clear Harmony and the Clear Wisdom, you can see right on the top. The lower half of the circular is statin intolerant, Clear Serenity, Clear Tranquility, and sufficient number of diabetic patients have been included, roughly 20 to 30% as you can see on the slide. What you have to remember that there is 15% reduction in LDL when it is added to statins. 25% reduction if the patient is not on statins, because both act to the, and 35% reduction if you use Bempedoic and ezetimibe, which is substantial. The tolerance is good except uric acid and gout. So this is data very briefly on the Clear Harmony and Clear Wisdom trials. As you can see, both these trials are patients on maximally tolerated statins, 2,000 patients or so, ACVD, FH, LDL more than 70, baseline LDL 103, maximally tolerated statins in the Clear Harmony and Clear Wisdom also nearly same type of patients, follow-up 52 weeks. And you can see LDL reduced by 16% or 15% in both these trials. These trials, when you take on statin, the reduction in LDL is 15%. And very interestingly, the CRP got also lowered, 22% and 18% in Clear Harmony and Clear Wisdom. And CRP we know is in, if you lower it, inflammation is decreased. Inflammation is an integral part of atherosclerosis and plaque rupture. So if you are lowering CRP, it is likely to produce additional benefits. We have very interesting data from this Australian paper. When Bempedoic acid used in 180 milligram, ezetimibe 10 and atorva only 20, look at 6 weeks, look at the results. 63% reduction in LDL cholesterol. So this combo is a great combo, triple combo. PCSK9, we have 50 to 60% reduction, so LDL reduced to 63%, non-HDL 60%, total cholesterol 47, ApoB 53, and his SRCP, high sensitivity CRP, 47%. So great data, and look at this, 90% of patients achieved LDL goal less than 70, 58% achieved LDL goal less than 55, so great triple combo for high-risk patients when you are not able to use PCSK9, because the second place where Bempedoic acid comes into action is the statin intolerant patient. This is the NLA 2020 classification of statin intolerance, which means you have to use at least 2 statins, including at least 1 at the lowest subgroup before labeling a patient as statin intolerant, which may be complete or partial. So what is the data of Bempedoic acid in statin intolerance? We have these 2 trials. I told you the Clear Serenity and Clear Tranquility. The data is on the screen, and the reduction you can see with statin 15%, without statin, statin 25%, and when you use both, I'll show you the 35. So very easy to remember, 15, 25, 35. Look at the reduction in LDL, 23%, 23 round about 25%, great reduction. And HSCRP, look at this, 32% and 25%, which is also beneficial. So this is just an overview of the Clear trials. You can see LDL reduction, Clear Harmony and which are on statin, 15%, on statin intolerant patient roughly 25, which is here 23.6 or 22, and great reduction is in the high sensitivity CRP. So what is the data on dual combination of Bempedoic acid, which means Bempedoic acid 180 plus ezetimibe in statin intolerance? This is the data that when you use these agents, if you use Bempedoic alone, 25%, this is without statin. And when you use both, look at, this has gone up to 39%, which is great. This is another data of combination. You can see 36% reduction in LDL, which is phenomenal. So what should be the strategy for statin intolerance? Never, never, never forget statins have pleiotropic effects which are highly beneficial. Always, always try to have statin on board as far as possible. But in statin intolerance, we sometimes tried bi-weekly or once weekly statins, atorva, rosuva, and then they are stopped. But this is also not an appropriate strategy. If you have statin intolerance, never, never forget pitavastatin, which hardly any statin intolerance. Therefore, if you have a statin intolerance, the best combination in the Indian context is pitavastatin, sorry for the spelling mistake by the steno, pitavastatin, ezetimibe and bempedoic acid, because PCSK9 cannot be afforded by vast majority. In the West, people use PCSK9 also. Now this is the pool data on bempedoic acid, over 3,500 patients. What do we say? Same thing is repeated. Statin intolerant, patient, reduction in LDL and statin. But this is an overview of these beneficial effects. You can see all hazard ratio are to the left. Even the confidence interval is to the left in all subgroups. So all subgroups, whatever subgroup you assess, all subgroups, all these large number of subgroups have been studied. So when we look at the side effects, only bothersome side effects is the uric acid problem, which I already taught. Tendon ruptures are very rare. Otherwise, all other side effects are seen only minority of patients. You have some elevation of the liver enzyme, sometimes anemia, and diabetes is decreased by bempedoic acid, not increased like the statin, which is again, I'll show you the data. This of course I will. On the other lipid parameters, non-HDL, total ApoB, all are decreased, and we are keenly awaiting the result of the clear outcome trial, because all these trials which I've shown are not outcome trial. What is the effect on diabetes, pre-diabetes and normoglycemia? Again, very interesting data. You can see diabetes, when you use these patients in diabetes, HbA1c is decreased unlike statins. Pre-diabetes HbA1c is decreased. Normoglycemia, no much effect. When you look at the weight reduction, which is also Dr. Selja pointed out, is very important. This reduces weight in diabetes, in pre-diabetes, normoglycemia, nothing. So additional advantage besides targeting inflammation is diabetes is decreased, weight is decreased. These are additional features of bempedoic acid which are not seen with statins or ezetimibe. And look at this. Diabetes, there is a reduction in the new onset diabetes. And again, this also shows new onset diabetes is decreased. Why it is decreased, I think it is Dr. Bansi Tabu and others who will tell you that this causes activation of AMP and suppress the mechanism. I am not much bothered about. This is another meta-analysis, and you can see reduction in LDL is substantial. CV wins, there's a trend towards benefit. And new onset diabetes, again, it is to the left of the midline. So will bempedoic acid be a game changer for lipid management in Indian context? If we talk of high-risk patients like established ASCVD, HeFH or other high-risk patients, LDL targets are usually not achieved with statins and ezetimibe. I've already shown you the data, and this number may mount up even up to 70 or 75% in the high-risk patients. So we have now bempedoic acid, which results in significant reduction in LDL on top of statins, and reduction in LDL occurs independent of the baseline statin use. And I've already showed you this triple combo when 90% patients achieved LDL less than 70, which is our goal as per AACC, 58% achieve LDL goal less than 55 in the very high risk patient according to the ESC 2019, and this will help to minimize the use of SPV because they are very costly agents beyond the reach of a common man. So utilize this triple combo. Then what about statin intolerance? Utilize the combo of pitavastatin, ezetimibe and bempedoic acid. If you are not able to use atorva, rosuva, Don't try to remove statins from your protocol. In the context of statin intolerance, please utilize pitavastatin, which is available in India also. They decrease CRP by 20%, which decreases inflammation, plaque rupture. All of us know all inflammatory cells collect at the site of plaque rupture when we take biopsies from rote ablation or others. T20 does not adversely affect glycemic control. In fact, it decreases diabetes, decreases new onset diabetes, and in summary, Bempedoic acid is useful addition to the therapeutic armamentarium of lipid management. Use of Bempedoic acid is not associated with muscle side effects which are there with statins, and utilize Bempedoic acid, which is now well in your practice, for the high-risk patient who have not reached their LD goals, which is not uncommon, and for the statin intolerance. So obviously, Bempedoic acid is going to be a cost-effective game changer for the very high risk for lipid management, and all of us know lipid management is so crucial, and stringent measures must be taken to achieve the target of LDL cholesterol. Thank you very much for your kind attention.